Our next speaker for the day needs no introduction. One of the finest pediatric surgeons, he takes up the most difficult cases as a challenge and is inevitably successful. I invite Professor Dr. Velmurugan sir onto the stage to shed some light on pediatric surgery for the pediatrician.
Good morning, everybody. It's such a pleasure to talk to a young audience. We as super specialists rarely have that privilege. I should thank the organizers, particularly my friend of 30 years, Dr. Srinivasan, for giving me this opportunity. You see, pediatric surgery as a super specialist, my problem is not much. You see, when a patient comes into my clinic, it's very obvious he's got a surgical problem. It has to be referred to me by another specialist or a super specialist. I have to just concentrate on management. I have to invest my mind only on the management. Unlike you people, you have a much more onerous job. Out of around 50 patients, normal patients are coming for nuisance, value, anything, for immunization, for URI, constipation and all that nonsense. You will have only 1 or 2 pediatric surgical pickups. Okay? Ominously, it will slip in. Nowadays, these cases don't knock on your door and they just slip under your door. Okay? It's up to you as pediatricians to identify and advise them properly. Your name is made or broke on that, because nowadays patients are very unforgiving, especially the parents. The common refrain of the parents is, sir, in the tongue tie ipo pannanuma. Ayyo, I've been seeing the pediatrician right from the day of birth. The only thing he or she tells me is about immunization. I've been telling about this undescended testes, I've been telling about this tongue tie, telling about this hernia. He is not bothered. He said, apram paathukalam. See, there the trust is lost. Now, from that time onwards, if they have a contrary advice, they will treat you only as a backup pediatrician. They'll come to you only on Sunday evenings when the regular pediatrician is not available. So, it is up to you to, all these lectures help you to identify these cases and guide them properly so that you increase your patient confidence. Now, my endeavor over the next few minutes will be to highlight certain problems, because what the mind does not know, the eye will not see. So you should see a lot of problems. And then especially since most of you took pediatric surgery as a vacation in ICH, so it is important that you see these cases. And I am biased towards newborn surgeries because I have seen a lot of blunders there. Now, it is the endeavor of every pediatrician attending pediatrician at birth to push in a feeding tube, a stiff feeding tube, not a fire feeding tube which will coil in the mouth, but a stiff feeding tube, preferably of 10F size, down the nares on the floor of the nostrils, down into the stomach. Okay, it will make out 2 diagnoses. Normally it should go freely. Inability to pass, so it is either a tracheoesophageal fistula where there is a typical obstruction about 10 centimeters from the nares. It has to be felt. Even if a pediatric surgeon comes and lays a TF on an X-ray, remove the NG tube and put it again and feed. You will never miss it in life. There will be a typical, your fingers and wrist will remember it for life. So whenever there's a diagnosed TF made, just pull off the NG tube and put one again and see. You will never miss it, because X-rays can miss this. The latest PVC tubes you get in government service now, they are not even radio opaque. So it's very difficult sometimes to make out. This is how diagnosis of TF is made. Now, in TF, I would say it's a relative emergency. The problem in this TF is twofold. One, this is the commonest type where the upper pouch is blind and the lower pouch is connected to the trachea near the carina or to the right main bronchus. Now, the problems are twofold, as I said. The upper esophagus collects saliva. Saliva is the only thing where the secretion cannot be controlled, especially all these digestive juices. So, this saliva overflows into the tracheobronchial tree and causes a pneumonic patch. Second, and it will worsen the condition. It will make it a negative anesthetic risk. The second, this fistula there will leak gastric and biliary contents into the tracheobronchial tree, causing chemical pneumonitis. So that's a double whammy. So the lung is going to be affected by the saliva from up and the gastric contents from below. So the lung is going to become progressively worse. You cannot squeeze the lung or dry it up by waiting in your newborn ward. It is imperative, and this message, please take it. This it is a emergency. You'll have to go and do a thoracotomy and ligate this fistula. Only then the lung will become dry. Upper pouch can be controlled by steady suction. So thoracotomy is an emergency in TEF. Do not wait for an auspicious time for the surgeon, echo, all that is right. You can do a bedside echo, do a functional bedside echo and take the patient up for surgery. So TEF is an emergency. That's a lesson from today. And the other variant is a pure esophageal atresia, where again there's a blind upper pouch and the lower pouch is also blind. So no air enters from the tracheobronchial tree into the abdomen. You have a gasless abdomen. Here we do upper pouch suctioning, do a gastrostomy so that to improve the weight, and then we do a thoracotomy and do a delayed primary anastomosis at 6 to 12 weeks. So if you have a gasless abdomen in a suspected TEF, it is a pure esophageal atresia, and it is important to always take an X-ray chest and abdomen. Many times in pediatrics, just a pure X-ray chest has been the downfall of a pediatric diagnosis. Diaphragmatic hernias, eventurations are missed. ICDs have been inserted into the bowel in ICH many times, only because somebody has not taken an X-ray chest and abdomen. Always an X-ray chest and abdomen is mandatory in newborns, or in pediatrics for the matter. And then the other problem is a choanal atresia. I don't know how many of you have seen this. I've seen quite a few in my 27 years as a pediatric surgeon. The problem is many cases die without diagnosis. Why? Newborn is an obligatory nasal breather. He doesn't know how to open the mouth and breathe. So your choanal atresia is either a membranous or a bony obstruction in the posterior nares. Okay? The nasopharynx, posterior part of the naropharynx. It's either membranous or rarely bony. So if you have got a bilateral choanal atresia, it's incompatible with life unless it is diagnosed and an airway is put into the mouth and fixed like this. So it breathes through the oropharynx. Then we take it up for surgery over the next couple of days. We perforate the membranous diaphragm or the bony diaphragm and then do a dilatation, serial dilatation. So choanal atresia should be thought of when the child, we have children brought dead sometimes with bilateral choanal atresia because the child simply cannot open the mouth and breathe. And then respiratory distress. It's a common thing which in pediatrics we think of a diaphragmatic hernia, eventuation diaphragm. Most of these diagnoses are now made antenatally with an ultrasound. Now when you're faced with such an ultrasound diagnosis, when your obstetrician calls you and troubles you, they're all troubled, you have to tell them, whether the mode of delivery is obstetric or not. Be careful about talking to them. They will say the pediatricians are only elective LSCS. Elective LSCS, it has been proved by studies, has got a mild survival advantage. So you prefer an elective LSCS at or near birth. Okay? There is no reason to terminate a child with diaphragmatic hernias. Many children have been advised termination by a famous cancer center. They are now useful members of society today. Okay? One of them is even a doctor. So, which I have seen, I have said, no, we will do it. Now the child has joined MBBS. So, diaphragmatic hernia, especially if it is diagnosed at the second trimester or later, is not an indication for termination. Now, you know how to diagnose this. I said you should take an X-ray, chest and abdomen. And it is important that you don't do bag and mask ventilation. You don't want to distend the bowels or the stomach inside the chest. And then it's mandatory you put in a tube into the stomach. Okay? In a diaphragmatic hernia, rarely does the stomach go up. It goes up only in eventuation. So you put an NG tube. You will see the findings. You will have, if you have just taken an X-ray chest, you would have missed this continuity. You would have it is possible that you can think of a staphylococcal pneumonia or something else. So, or if a dilated stomach is being thought of a pneumothorax sometimes, you should take an X-ray chest and abdomen. Here you will see the bowels in the chest, continuity of the bowels with that in the abdomen, relative paucity of bowel gas in the abdomen, mediastinal shift, and the heart is on the opposite side. So the diagnosis is simple. There is no need to actually indulge in semantics, whether it's a eventuation or diaphragmatic hernia. The pathology is the same. The treatment is the same. Either there we do application or excision repair. Here we repair the whole. The essential pathology is diaphragmatic hernia and eventuation in the newborns. Is not the bowels in the chest. There is no physical problem as such. The problem is the lung compliance. You got a hypoplastic lung, poorly compliant lung, pulmonary hypertension, poor pulmonary perfusion, and all the attendant problems of that. So it is only a medical emergency. It is not a surgical emergency. The treatment of diaphragmatic hernia CDH is delayed or very delayed repair. Okay, ideally after 48 hours, not before that. What do we do in these 48 hours? Stabilize the child, improve the hemodynamics, improve the oxygenation, reduce there is a transient pulmonary hypertension, treat that. How do you treat pulmonary hypertension? Anything which increases prearteriolar sphincter spasm, like an acidosis or hypoxia, all that should be corrected with ventilation, gentle ventilation. Okay, go all out to get the FiO2 down and the ABG stabilized, and then we take up these cases. This is a classical posterolateral defect, Bogdal-X defect. And then you would think this diaphragmatic hernia presents only in the newborn period. No, 2 weeks back in child rest at night 1 o'clock, there's a call saying the diaphragmatic hernia has come. I said, what is the age? Newborn. The call was on the 4th floor. It was a 3.5-year-old male which was presented to a senior pediatric surgeon in North Madras with dysuria. Okay, the child has been vomiting possibly and didn't pass urine well, and it presented dysuria. He has thought of cystitis and asked for an ultrasound KUBU. A sonologist in the local hospital in Tandayarpet has said the bladder is normal. It has gone to another pediatrician who has taken a former colleague here, who has taken an X-ray, who's taken an ultrasound. It shows none of the bowel loops are here, all of them are in the chest. This is a 3.5-year-old female who had no respiratory distress at all. It has presented with abdominal pain, colicky abdominal pain. So the lesson here is, if you are in doubt about anything, you will be safe if you can do an X-ray chest and abdomen or an ultrasound with a qualified sonologist. As young pediatricians, it is imperative that you develop a rapport with a radiologist, a sonologist for your, this is a partnership for life. I depend on only 2 people in my practice, and it is up to us to give them cases, get the follow-up and have a close rapport with them. They are good sonologists throughout the state. Tirunelveli, Kanjipuram, Salem, Trichy. It is up to you to identify them. It is for your benefit and not for theirs. Remember that. Congenital lobar emphysema. There is another common case of respiratory distress which you see. Congenital lobar emphysema presents at birth. Okay, there is another lobar emphysema which presents later in infancy or childhood, where there will be repeated episodes of bronchiolitis or due to obstructions of the bronchial tree, where you have to do a bronchoscopy to rule out intrinsic obstruction. Whereas congenital lobar emphysema, you will have a history going back to the newborn period. Here, classically one lobe is hyperinflated with pressure on the lower lobe. It is classically in the left upper lobe. Remember, it is, I teach my PGs this way. This is the commonest. Commonest in the left upper lobe, then right middle lobe, and then the right lower lobe. That is how the, how common it is in lobe wise. Here you see the inflated upper lobe. It is important differentiated from a pneumothorax. You will see the bronchovascular markings. Compressed lower lobe because of the hyperinflation, herniation of the mediastinal pleura and shift of the mediastinum. Okay, and all these, it is a simple lobectomy in these cases, but then there is a rider. Sometimes CLE is multilobar, and it comes much later, sometimes the other lobe involvement. Those are few, but then they do occur. Okay, when we open a congenital lobar emphysema, this is a typical lung. Normally when we pull out a lung, when you compress, all the air goes off. It is so soft when we pull it out. Here you have a non-compressible lung. It looks like, what do you call this, air-filled sponges you see in packing material. So it is like that, it never deflates. Okay, that is the classic of a congenital lobar emphysema. It just bubbles out of the chest. And then the other problem, which is increasingly diagnosed antenatally, is a CPAM. It was previously called congenital cystic adenomatoid malformation. Now it's called congenital pulmonary adenomatoid malformation. What is this? These are cystic lesions of the lung, which may be macrocystic as seen here or microcystic. Typically involve one big lobe. They cause mass lesions. They can get infected. They can push the other lobe. It is very difficult to make it out just on an X-ray. Okay, CT is mandatory to categorize these lesions. If you take an X-ray chest, you will see a huge air-filled pocket. It may be even, what would you done in this on your duty? You'd have put in a tube, as somebody here has done. Okay, despite of the tube being there, air is still there. Okay, that is your clue to diagnose, something more than just a pneumothorax. So CT revealed a macrocystic lesion in the lung. The treatment is lobectomy. But then there are cases which are diagnosed antenatally and they are asymptomatic. They come to pediatrician. Nothing is practice outside is not simple. Even in the ICH anywhere, people will come to you with the problem that CCAM has been diagnosed, but my child is all right. Do you have to do anything at all? Okay. Now that is the problem. That is the situation you will face. Now perioperative complications in lung surgery is up to 10% of cases will have problems. So we'll have to weigh risk, the way the risk versus the benefits, but still surgery is needed in asymptomatic CCAM because there is an increased risk of malignancy in the cystic lesion. It may be a bronchoalveolar carcinoma or a rhabdomyosarcoma. So if you diagnosed a CPAM or a CCAM, this has to be operated. And another important thing, imaging by whatever means available today. The latest CT cannot diagnose, differentiate between a CPAM and a pleuropulmonary blastema, which is a high-grade malignancy. So for these reasons, a CPAM, when diagnosed, should be operated when it is technically feasible. Then coming to simpler problems, non-bilious vomiting. The most common cause is an IHPS, as we all know, which typically presents in the second or the third week of life, and then it progressively causes dehydration and the typical metabolic alkalosis. However, you always think of a duodenal atresia or an annular pancreas. In a duodenal atresia, you will have a distended stomach and the first part of the duodenum, a double bubble sign with an NG tube there. Here, if you want to accentuate this double bubble, you push in air to make your diagnosis, as has been done in this case. Okay. Annular pancreas is made out confirmed only on a contrast CT, nothing else. And barium and all these things are passed. We just do a contrast CT for those cases. And this is the commonest cause of infantile hypertrophic pyloric stenosis. It is not congenital hypertrophic, it is idiopathic hypertrophic pyloric stenosis. It is a common problem. The treatment is a laparoscopic pyloromyotomy. That is new. Okay. When I trained, we used to do only open pyloromyotomy. Now, for the past 4 years, we do only laparoscopic pyloromyotomy. There are 2 cases in the post-op ward in ICH now. All laparoscopic pyloromyotomy, you will say what is a small incision, but then it is so easy to do it by laparoscopy. It takes only 5 minutes. And of course, you don't take an IHPS immediately. It's a medical problem. You'll have to treat the hypochloremic, hyponatremic, metabolic alkalosis, wait for the child to settle. It may 2-3 days or even 4 days, and then take it up for surgery. The bicarb is typically very high in these cases. The highest I've seen is 42. But then the bicarb, I don't try to reduce it fully. Bicarb of 30 is in fact good for surgery also. Helps in recovery. Now coming to bilious vomiting. Bilious vomiting is malrotation unless proved otherwise. Last month there was a PG posted to surgery who said that when we presented an X-ray of a 3 kg term normal child, healthy child, presenting with bilious aspirate. We put up the X-ray and asked the diagnosis. The person said sepsis. I was shocked. Okay, so the diagnosis when there is bilious vomiting, it is malrotation unless proved otherwise by imaging or ultrasound. Okay. Now, how does malrotation present? What is malrotation? It's basically, as I have explained to my thing, you have the whole midgut. You have the midgut which hangs free like this in a narrow base of mesentery. It's a midgut which hangs like this. It goes out, comes back, and then it doesn't fixes. It goes in the extraembryocoelom, comes back at 12th fetal week, and then by the oh, you're going to project me. So what happens is, when the bowel, it hangs like this on a narrow base, it can twist at any time. Can the camera come on this, Tambi? On my hands. It twists at any time on its vascular axis, on the narrow mesenteric base. When it twists like that, the superior mesenteric vein, which is usually lateral, and the superior mesenteric artery are compressed, and the bowel goes in for strangulation. So you have gangrene. So unless you intervene early, you will, and detort it, you're going to have a problem. You lose the whole midgut, and midgut is the only thing which cannot be transplanted. Okay? The child, you will lose the child. So SMV is always lateral. All veins external jugular vein, the IVC are all lateral to the major vessels. Remember that SMV is lateral to the superior mesenteric artery. So you have a volvulus. Once it twists, obviously the stomach is obstructed. You have a bilious aspirate. You have a scaphoid abdomen because there is nothing to fill the bowel. You have a scaphoid abdomen. You sometimes may have a prominent stomach. And then in later cases when the congestion is bad, you have the bowel goes in for necrosis, you have bleeding PR. Bleeding PR is an ominous sign in malrotation. As you said, you take an X-ray. This X-ray is enough for a diagnosis. You have a distended stomach and paucity of distal bowel gas. Paucity of, it should immediately, you should call for a sonologist and take an ultrasound. Okay, ultrasound will show a altered SMV should be here. Since it has twisted, I have shown it has gone anteriorly, and in late cases it goes to the right. So it is twisting on itself, the blood supply. So this can be made out by any pediatric sonologist. So please ask for don't just ask for a malrotation ultrasound. Ask to look for SMV XMV axis. If it is complete twist 360 degrees, superior mesenteric vein might come this side again in a complete torsion. Again, it requires a good sonologist to see the world. When there is a doubt, please open up. Otherwise, you will have the whole midgut will go in for gangrene. You would assume this is being in a tertiary institution, me working practicing only in Chennai, I will not see these cases. But I do see one of these cases every year. You can't do, you come out of the theatre and tell the parent this child will not live. Finished. And this is a completely preventable problem. When does this malrotation and torsion occur? It can occur commonly in the newborn period, but also at any time in birth. What is the oldest which has been recorded? At 54 years? Okay, my age. So it can occur at any time, and that's why it is so important to know that any bilious vomiting, you'll have to think of a malrotation. Coming to delayed passage of meconium, all of you know it may be an anorectal malformation, atresia, Hirsch, or meconium ileus, or hypothyroidism. The previous speaker was speaking of thyroid. It is one of the important manifestations of hypothyroidism. You have a delayed passage of meconium, or the child passes meconium. There is a vague abdominal distension, vague loopy abdomen, and hypothyroidism is the cause. And the problem is, in the first 1 week, we are not able to make the diagnosis. We go by can anybody, when you are not able to do the TSH, only at the end of first week, you'll know it is elevated or not. How do we get a clue that it is hypothyroidism in the newborn period? X-ray, both knees. Okay, good. Now, what epiphyses will you look for? Lower tibial or upper tibial or lower femoral? What is more important? It is the tibial epiphysis which is more important. Okay, not the lower femoral as is commonly thought. If you have a well-formed upper tibial epiphysis, you'll know that it is unlikely to be hypothyroidism. You look not just the size, you look at the shape, whether it is crenated or not, or it is a perfect semicircle, perfect sphere, sorry. In anorectal anomaly, the diagnosis is straightforward. But then why am I talking to pediatricians about it? When you encounter such an absent anus, the obstetrician is going to call you first, and then once you see this, you don't try to pack off the child to the pediatric surgeon, ask them to travel miles at night and then odane poi or surgeon poi paranga. I am not going to do anything for the next 24 hours. Okay? I have to wait for the child to cry, swallow air, and the air to come distally, so that I know the lower level of the problem, how far the bowel has formed. Okay? So there are two important things. One, don't panic. You are going to take a prone translateral view. We no more take invertograms. We take only prone translateral pictures, cross-table pictures, and then do not put nasogastric tubes. This is a common problem I see in newborn units throughout Chennai. People put NG tube, immediate or NG tube, put fix panni vechidunga. Yeah, we need air to go down the bowel. Now, if you put an NG tube, where will I know the level of the problem? So don't put NG tubes in anorectal problems. Okay, so once after 16 hours, we allow enough time for the air to go down, for the child to cry. You can actually make the child cry, push in air if you need, and then we know in this case it has travelled very close to the perineum, where only a single stage perineal problem. I will do a anoplasty here, and this I will get the thing. That is the end of the problem. However, If it is going to be, if it is at 16 to 18 hours, it's going to be only high up, above the, at the level of the sacrum, above the PC line. This is the PC line, pubococcygeal line. I had to do a colostomy, and this is committed to a 3-stage procedure. So it matters. So nothing is going to happen in the first 24 hours, you can wait. And especially in girls, you can wait even for 3 days. Invariably in females, there will be a recto-vaginal or a rectovestibular fistula which is not seen. It will slowly open up. Okay, there is no hurry to go in and do a colostomy where a single stage procedure would suffice. Meconium ileus. See, of all the problems, atresias, Hirschsprungs and all these cases, there is no distension at birth. The child cries, and because of the atresia or obstruction, the bowels dilate. But this is one condition where dilatation is present even in fetal life. Because of the character of the deficiency of exocrine pancreatic secretion, the meconium takes the character of cement. Okay, it's very sticky. So the bowels are, there is no propulsive peristalsis. The bowels are dilated. Even if an antenatal ultrasound shows dilated bowels or echogenic bowels, you should either think of atresia if it's echogenic, dilated, mixed with dilated bowel, it is meconium ileus unless proved otherwise. And they will have distension or palpable or visible loops at birth. Atresias, they don't have loops at birth because it has to swallow air and then the atresia becomes manifest. Here the loops are present at birth. You have what is called the soap bubble sign on X-ray, that is air trapped with the meconium. Can you see that? That is the soap bubble sign. Okay, with this, and secondly, most important line, on serial X-rays you have a fixed loop. That is again important. Because it is fixed, it has got a cement like meconium, the bowel doesn't move. So in late cases, it can occur postnatally or even perinatally, you will have meconium peritonitis. Okay, so the central bowel loops with fluid around, complicated meconium ileus. When you open window laparotomy, this is how the meconium is sticky, filling the bowel and acting as a physical impedient. We'll have to physically extract all this, loosen it, put liquid paraffin, wash the bowel of this meconium and do a ostomy or do a primary anastomosis. The gastrographin enema in selected cases is both diagnostic and therapeutic. Gastrographin is an osmotic laxative for the colon. We put it down up the anus into the under fluoroscopic control. You can see the meconium pellets there. This osmotic laxative loosens up these pellets and sometimes it passes off. It occurs in milder forms of meconium ileus. Coming to atresias, as you know, jejunal atresia, jejunal atresia, here these cases, they are really not emergencies as we thought of earlier. 25 years, 27 years back, we used to operate on them in the middle of the night. Unless it is complicated by a perforation, jejunal atresias, you can wait and do the surgery at leisure. And the results are very good in jejunal atresias. You see, this is a simple atresia and this is a complicated apple peel type 4A atresia. See, many years back when I was a postgraduate in the early 90s in ICH, atresias, we used to ask the parent to pray. Okay, but now atresias, rarely do we have problems with atresias now because of two things. Because one, the MNB people take very good care of these children, the MNB postgraduates and the PGs. Second is TPN. In private, the longest I had to go was sometime last year where a child was put on TPN for 92 days and it went home. Okay, so if you supported the TPN and other supportive measures, these children do look, because it takes time. It is not only that the bowel is missing, the innervation is also missing. That is the problem. For the innervation to come back, it takes nearly 2 to 3 months. So they do well with atresias, but then it was a dreaded problem before. Again, you will have antenatal ultrasounds showing that bowel is echogenic, probable atresias. Don't get scared. Some of these echogenic bowel become recannulated later. My children, twins, 25 years back, antenatal ultrasound, they said, Mediscan Suresh told us, sorry, he was sweating, Vale, please come. Your both children seem to have intestinal atresias. Okay, I was a training pediatric surgeon and I was, pretty worried. But then my chief, Dayalan, told me at that time, see, these still disappear in the last trimester, which it did. And now I'm thankful for that advice, and they are now doctors now. So atresias, don't worry about the antenatal ultrasound. They will show echogenic bowel, but in the last trimester, they might even clear up. Hirschsprung disease. This is a functional obstruction. You see, you all know that there is a lack of ganglion cells in the terminal bowel. Ganglion cells are of neural crest origin. Do I have time? Yeah. Ganglion cells are of neural crest origin. They travel in the gut craniocaudally. So they somewhere due to some unknown reason, this progression of this neural crest ganglion cells is arrested, commonly at the rectosigmoid junction, or sometimes even further up in the terminal ileum, in the colon, where you have long segment Hirschsprung also. Classically, it is at the rectosigmoid junction. So what happens if it stops here? The ganglion cells stop here. This is the transition zone, and this is the aganglionic bubble, which is does not, these ganglion cells, they mediate propulsive relaxation. They relax, they mediate the relaxation of the bowel in anticipation of a bolus, a fecal bolus. So when there is failure of relaxation, the problem is not contraction, there is a failure of relaxation. Then in a chronically contracted state, you have a transition zone, and this is the ganglionated bowel. So what we do, in this case, somebody has done a laparotomy and done a colostomy. I personally, over the past 15 odd years, I do only, if it is diagnosed in infancy or the newborn period, in my unit, me personally, we do only a transanal endorectal pull through. Okay, we put the patient on bowel washers, get the bowel size down, and do a endoanal procedure, pull down the bowel endoanally. Okay, there is no scar, single stage operation, parents are happy. So this is about Hirschsprung's disease. So bleed per rectum, we thankfully they are much less today. Especially because NNEC has come down so much from what we had seen 20-25 years back. Neonatal necrotizing enterocolitis, this is a problem where there is the gut gets infected, the gut wall gets infected, there is a transmigration of gut bacteria into the bloodstream causing sepsis. So you'll have to closely monitor these children. See, again, this is a medical problem requiring antibiotics, serial CRPs, platelet measurements, blood cultures, and most important is repeated X-rays. The first X-ray will be normal. You'll have to do X-rays every 8 hours in every case of suspected NEC, because the first X-ray is normal, the next X-ray will show this pneumatosis. That is, normally you see the bowel wall edema and then gas within the bowel wall, pneumatosis, and then this is the air in the porta hepatis, in the portal vein. These are actually early signs. Later it goes in for full thickness perforation and causing a pneumoperitoneum. Okay, if you notice, we have taken a translateral view again. We don't take an erect view. We either take an AP view or a translateral view, and then you can see the gangrenous bowel. Okay, so many cases of NEC, early cases, even if there is a pneumoperitoneum, we are able to get away now with a flank drain, the child improves. Rarely when we open, we see patchy areas of patchy gangrene, there is a loss of bowel, we have to do an ostomy and hope and pray that everything clears. So the indications for surgery in NNEC are pneumoperitoneum, clinical deterioration, and if you have an abdominal mass with intestinal obstruction. Relative indication is the surgeon decides that there is an increasing tenderness or distension and or the abdominal wall discoloration, we again tend to open up. Coming to biliary atresia. Biliary atresia is a dreaded problem. It is not congenital, mind you. It is an acquired, atresia of the progressive atresia of the extrahepatic biliary tract. So there is no corresponding dilatation proximally. This atresia extends into the biliary radicals also. So the problem is to identify them early and take it up for early surgery, preferably before 8 weeks. So that is the time it is. How do you diagnose these cases? It's very obvious. This high clinical index of suspicion, time should not be wasted on extensive infective screening, HEDA scans, and so on and so forth, with opinions between medical GE and nasal and endoscopy and all that. Only one thing, if you suspect biliary atresia, do an ultrasound. If the ultrasound does not pick up gallbladder, you refer it to a surgeon. He will decide, depending on the time, whether a HEDA scan is, because a HEDA scan cannot be done tomorrow on a child. It has to be primed with phenobarbital, microsomal enzyme inducer, and then only you can do a HEDA scan. A HEDA scan should be a well-tempered scan. Suppose it takes about a week to do, you can't wait on the child. So what is the solution? You'll have to do a laparoscopy or a small mini laparotomy and go see inside whether there is hepatitis and do an operator cholangiogram. We inject dye into the gallbladder or whatever is there and see if there is atresia or not, whether there is free flow into the duodenum. In those cases, which is just a neonatal cholestasis, this act of injecting saline and flushing out the biliary tract will actually clear the problem. Okay, so biliary atresia, send it early to the surgeon. And then there is a question whether any questions on biliary atresia? Any doubt anybody has? Now, these are the days of liver transplantation, which is being pushed, sold Pediatricians are being commercialized with this liver transplantation business. Now, if you have got a case of biliary atresia, or 1 month old child with biliary atresia, would you prefer a Kasai or a liver transplant? Anybody? Okay, still Kasai is to be preferred. Okay, this is the international consensus because, can anybody tell the reason? See, when you do a liver transplant straight off, what happens is the child is going to an immunosuppression for 1.5 years. So you can't do any of your primary immunization at all. Okay, the child is, it is a sitting duck for any infection. Forget about corona. Any infection which goes in the air will kill the child. Okay, so Kasai, even when you have got a donor, is a bridging procedure. You have to do the Kasai and wait whether it fails and then take it up for, finish off the primary immunization and then take it up for transplant. Okay, despite all these, nowadays, all these transplant units are not talking much about 3 years back, they're talking about so much of transplantation for biliary atresia. Now the interest has come down because the survival, there are no 5-year survivals, 10-year survivals, whereas those after Kasai, Srinivasan, VSS son called me, he and VSS called me 10 days back and said they have seen a 10-year-old child, which I have operated in child is coming for a Kasai follow-up. Okay, so surgery for survivors are many here, outside. They have come into adulthood, but then Kasai transplant survivors I have not seen yet from a biliary atresia. They will survive for other transplants for cryptogenic liver failure and adult liver failures or whatever cause. I have survivors, I have seen 15-year survivors and all, but not after biliary atresia. I have not seen 5-year survival at all so far. So Kasai is the portoenterostomy is a bridging procedure prior to liver transplant for the purposes of primary immunization. Choledochal cyst, in contradistinction to a biliary atresia, here you have a dilatation of part or whole of the extrahepatic biliary apparatus causing it. So a choledochal cyst is usually made out in an antenatal ultrasound where we advise surgery before 60 days. I personally do it in the first 2 months of life before cholangitis. What are the problems? You can have a cholangitis and cirrhosis of the liver. I don't want these problems. Having made the diagnosis, you have to operate. I don't want the parent to come back and tell me later, if you had operated early, we could have avoided all this. So we go in early. That is the international consensus. Do it before 2 months of age. What I have put it up is not my personal, it is the international consensus. So I in fact prefer to do it at 45 days of age due to certain technical reasons. But then a choledochal cyst is sometimes insidious. It occurs in children. It will present only with abdominal pain in a 6-year-old child. That is why in every case of abdominal pain, you will have to do an ultrasound to make out whether there is a choledochal cyst or not. Now, this is an interesting problem. You would not have seen this slide anywhere. Brachial plexus injuries. We do see this, okay? Right. What do you advise? Can I have a volunteer? What do you, Ania, tell me, if you have a child is 2 weeks old with a brachial plexus injury, it's got an Erb's palsy. Of course, it can be upper trunk problem, C5-6, or a lower Klumpke's paralysis or a total paralysis. What would you do to a child which is 2 weeks old? I wanted to be interactive. I see 3 people already sleeping now. You know, it's very depressing at 10 in the morning. So, what would you do? Take a guess. Passive physiotherapy. No, she is telling if she look for hand grip, when it's okay, they leave it. They will advise passive physiotherapy. See, sit down, Inia. I will tell you let's not waste time. What happens is, the commonest advice given to a pediatrician, because it is handled by the obstetrician. They become very defensive. We are sitting in an obstetrician's club, but still I am telling you, they become very defensive. Discharge panniduvanga first. Then it goes to the pediatrician, and the pediatrician says, then they will send it to a physiotherapist. For physiotherapy, sling, as Inia says, it will go around the world. Okay? Nobody, you won't know whether to refer it to have you ever thought, who will you refer it to? Pediatric surgeon, plastic surgeon, neurologist, physiotherapist. So you will have these non-medicos, I don't want to use harsher words, who will give all sorts of treatment for these. The thing, you will have a child which are unused arm. The thing is that it is important to do in the newborn period or in the first month, you need to anesthetize the child and do an MRI. How many of you know that? You will have to do an MRI. You will have to, these nerve conduction studies are all so old. They are so unreliable. It is very difficult to do it in children. You will have to do, even 25 years back, we used to send it to Vijaya for nerve conduction studies, no more. you have to get an MRI done under anesthesia, because a child has to be into the MRI, into the gantry for 15 minutes to get a good MRI. We do an MRI study and we quantify whether it is a neurotomesis, axonotomesis, or just a hematoma there, and then decide what to do. If it is a complete cut, we'll have to go in and repair the nerve, either primarily or with a cable graft. You can take a sural nerve graft and cable it and do it. I do it. We do 80 proline. It is being done in ICH for the past 7 years. Okay. I have got a plastic surgeon who comes, Dr. Balakrishnan from MMC. It is being done in our department. So, I am sure most of you would not be aware of this. That's why I am presenting this here. Okay. So, the treatment for this, you do get an early MRI, find out the level of injury and refer it to the pediatric surgeon. We will take the help of a plastic surgeon if necessary, because it requires a specialized thing. We go in, expose the trunks and the roots here, and it's a very difficult surgery actually. So, but then if it is a clean cut, we go and suture it. It heals faster. Okay. Children have come back with, I think we should present this in another meeting in ICH, so that more of you are aware of this problem. Okay. It should be early, and surgery within 3 to 6 months. Okay. By the time it comes to us, it is more than 1 year. It is too late. Severe fibrosis sets in. Now, pure organ sequence, micrognathia, time is running out. You know that there is the retrognathism because of hypomandibulism, and the tongue falls back as a result, causing airway obstruction. What do you do for such children? You do nurse them in the prone position so that the tongue falls out. Okay. Put an NG tube down into the stomach and start feeding the child. Usually they recover, and if they don't, you'll have to do a tongue lip adhesion. We bring out the tongue and fix it up to the lower lip with a button. We keep a button here, button on the lip, and take a stitch through and through the holes in the button, and then slowly the tongue comes out. That is the easiest way. We have done hundreds of those cases early, but nowadays I don't know, we don't get these cases. And then later we do a mandibular distraction, osteogenesis. The mandible is distracted. You make a cut, distract. Even yesterday was Friday. Do you know that the OMFS surgeons come to us, to our pediatric surgery theatre? I have arranged it for the past nearly 4 months now. We plastic surgeons, OMFS surgeons, all specialists come here. We are given the theatre to them on Fridays. Even yesterday there was a mandibular distraction done for severe. There are 2 such cases in my ward, S1 unit, C block, 2nd floor. Please go have a look. Okay. So, we do mandibular distraction, temporomandibular distraction for these cases along with the OMFS surgeons. Now, a poor urinary stream. A poor urinary stream is post-urethral valve. There are many conditions, but always think of an ominous problem, a post-urethral valve, and then that should be, poor urinary stream is not dysuria. Dysuria is painful micturition. See, any child should be, if it is an infant, when it lies down, it should have a stream out of its body. It should have a parabola out of its body. If it is able to stand, it should be able to stand and direct the urinary stream away from the feet. That is a good stream. So, you have to define a good stream. That is a good stream. It should not wet its feet or its body when it is lying down. That is a good stream. If it doesn't, please look for and rule out a posturethral valve, an ultrasound and MCU. If it is a simple dysuria, that is painful micturition. Kolanda pona alugudhu. That is a common problem. So, these 3 things, cystitis, commonest is a cystitis. It irritates the trigone and it causes irritation. Second, a vesicle stone. This is repeatedly being missed. 2 cases were missed this week. We went to the medical OP. One was a large stone in our department, because you don't think of a vesicle. So, you are thinking of a urinary tract infection. It will go to 2 or 3 pediatricians, do a culture will be negative, it will show some RBC, heavier antibiotic is given. Okay. So, what happens? Nobody has done a PR, forget it, nobody wants to do a PR nowadays. You can at least get an X-ray or an ultrasound which will make the diagnosis. So, when you have got a dysuria, the child tugs at the penis, kolanda pona alugudhu, mudichona kattudhu. So, that is dysuria, that is vesicle stone because of trigonal irritation. Think of always a vesicle. Are you missing a vesicle stone? Take an ultrasound, that will give you the diagnosis. And then, most importantly, something which is commonly missed, vulval synechia. See, how many pediatricians check the vulva in a female child which has got UTI? Very few. Many cases. I made a lot of money on this. Okay. They come to the clinic. They say that you finally, sir, periya problem, periya plastic surgery sonnanga. Vaangama cornerla vaanga nu solli, I just release an outpatient procedure. Okay, the vulval synechia. But then this child would have gone invariably UTI, 3 episodes, febrile UTI, ultrasounds taken, DMSA is taken it happens in big units. DMSA is taken because the pediatric nephrologist or the pediatrician has not seen the vulva. Okay, so please think of these things: cystitis, vesicle stone, and vulval synechium in every child with dysuria. Do not brand them as UTI. Okay, PUV, a simple MCU will give you the diagnosis. Dilated post-urethra, we do a primary fulguration. Even in the newborn period, here we do here and outside do a primary fulguration, unless of course we need a diversion for other reasons. And then phimosis again. We know it's physiological till 1 year of age because the inner prepuce is not secreting enough sebum. It doesn't slide. It causes ballooning, but the stream is always good. Remember, the stream is not affected in phimosis. Again, phimosis, simple skin problem. It doesn't cause ascending infection. Phimosis, இது பண்ணாட்டி மேலே கிட்னி கெட்டு போய்டும்னு சொல்லி I get references. கிட்னிக்கு இதுக்கு சம்மந்தமே கிடையாது. Okay, so all it's needed is gentle home stretching. Give a trial of gentle home stretching. See, ask the mother to dilate the prepucial. This is the most gentle person who can do. Don't ask the father to do. Don't ask the somebody else to do, you know. They will never. It is only the mother who can do the gentle home stretching by the mother. Forced dilatation, which used to be done previously, is should be avoided because it causes radial scars which will heal by cicatrization and worsen the problem. And then the role of steroid creams. Steroid creams is not indicated. You have so many papers saying that steroid creams and humosone and all that is very good. Please don't prescribe that. The effect of those creams is due to the emollient effect of the lubricant there, of the base. You have a emollient base, that is what causes. The same effect you will have with coconut oil. Okay, it is just that lubrication which opens the thing and not the steroid. And putting a steroid on an infected area causes balanitis, candidiasis, worsens the whole issue. And then in India, it's an OTC prescription. They will keep on giving this thing and lead on to a big problem called a whitening of that area, sometimes going up to balanitis, xerotic obliteration. This is also seen in cases where the neglected phimosis, the urine, the ammoniacal dermatitis causes the prepuce to become whitened. It is not just white, it takes the character and texture of dried orange rind, orange tol kanja eppadi irukum. It takes that texture and consistency, and ominously this extends even into the meatus, causing stricture and all that. So try to avoid this. Do an early circumcision. Inguinal hernias will not resolve spontaneously. I will rush through that because in small children there is lack of inguinal canal obliquity. Activities of normal living can cause the bowel to push out and strangulate. So hernias should be operated as early as possible. Newborn hernias, you have to do an emergency herniatomy, and older hernias you have to take it in the next available list. Undescended testis, can I have a couple of more minutes? This is my pet peeve because God created the testis so that it is at 4 degrees Celsius less than core body temperature. In summer it goes down, in winter it comes up to the body. The cremasteric muscle acts as a fantastic thermostat. But then if it is there for more than 3 months, what happens? There is heat damage to the testis. The biggest problem so you have to bring it down because it is irreversible. It is like keeping the testis in the oven. How will you cook the testis? How will you do it to a relative? Keeping it at body temperature, at a temperature 4 degrees Celsius more than what is necessary, it causes irreversible histological damage, documented earlier 6 months. So it is a bilateral, and secondly, it's a bilateral disease. These findings are seen in the opposite contralateral descended testis. So it has been proved that unilateral undescended testis is a bilateral problem which manifests unilaterally. If you have got a unilateral UDT beyond 6 months, this person will be subfertile. Write it down. You have a UDT not treated by 7 months, you are going to have a subfertile person because the opposite test is also not normal. So intervention, it should be at 6 months of age. Another pet peeve, a painful tender testis. What will you do? Any other volunteer? What will you do? Immediate surgical exploration in minutes, a fire brigade emergency. It should go, no need to do a hemoglobin, no, just get a consent and rush to the theatre. Okay, because it can be served only in minutes. Okay, no, there is no investigation in the world available today, neither a nuclear CT scan or a Doppler ultrasound. Nothing can rule out a torsion with certainty. A Doppler will show you peripheral vasculature and then you will keep quiet. At present I am going to the court for 3 cases, all my colleagues. One was an adult urologist, 2 are pediatricians. They have delayed, they are given amikazin for 5 days, 3 days, and then now the patient has gone to court. So do not, if there is a thing, just watch the case off, send it to us, at least write in the OP ticket, refer to a surgeon as soon as possible. Don't waste time. சாயங்காலம் போய் டாப்லர் பண்ணிட்டு அதுக்கப்புறம் சாயங்காலம் 6:30 மணிக்கு அவரங்க கிளினிக் வருவார், அப்படியே போய் பாருங்கன்னு ப்ளீஸ் சொல்லாதீங்க. Within minutes find out somebody who can handle this child. Okay, otherwise this will be the result. Okay, and then another thing, a button battery. A button battery is not as dangerous as is thought of because it is well sealed. Okay, contrary to popular, it doesn't open up that easily. How does a button battery affect the esophagus or the stomach? Not erosion, sorry. See, it's a charged cell. Okay, the esophagus is collapsed at rest. So, current flows between the poles, cation to anion, because of the charge in it. And as it passes through the mucosa, there is a catalytic damage to that. An electrical damage. That is what. It doesn't cause a physical erosion. It just causes a electrical damage to the mucosa. That is why it is most important that if it's an esophageal, if an X-ray shows an esophageal foreign body, you remove it and then don't say tata to the patient or the thing. That has to be categorized by an endoscopy and then an MRI to look for mucosal damage. Please do that. Otherwise, you will have egg on your faces. So, you will have to do an MRI and an endoscopy because of damage. If it comes to the stomach, it is a big lumen. Current doesn't pass through the mucosa. So, nothing much happens. It can be there even for 4 days. Nothing much will happen. And contrary to popular perception, a old battery is very safe. You ask, "Eppama vaangna toy? Eppa pannadunnu? Pudusa?" Then you have to be really worried because the residual capacitance is supposed to be, it will be much more rather than an old battery which has nothing. It is innocuous like an old man. So you just leave it like that. Old battery, it will come out. Nothing much will happen. But an young, fresh battery is much more dangerous. That is about a button battery. Vulval Sainike, as I have said, nothing important. Umbilical granuloma is just exercises, is putting rock salt and coming. Copper sulfate and silver nitrate are not to be used. And again, I have pediatricians referring patients, umbilical granuloma, இது போடுங்க. What is that? Mupirocin. போட்டுட்டு 3 மாசம் போட்டுட்டு இருப்பாங்க. See, no ointment of oil of any sort should be put on the umbilical. It should dry. To dry, after all, you can put alcohol dabs or leave it like that. There is no point in putting any oil on the umbilicus. This is what will happen. An umbilical granuloma will be there. Again, I'll finish with urinary tract infections. Urinary tract infections, any febrile UTI in any child of any age, it is up to you to look for and rule out renal involvement, pyelonephritis. And the only test which can diagnose pyelonephritis, acute or chronic, is a DMSA. You do a DMSA in every case of febrile UTI, and if it is positive and if the ultrasound shows any anatomical abnormalities like a dilated system, then you do an MCU. If there is no dilated system, MCU may not be necessary if it's not a male, but generally DMSA, ultrasound and MCU are mandatory in cases of urinary tract infection. You have to look for pyelonephritis and vesicouretic reflex. Again, abscesses do not heal with antibiotics. An abscess is a pus which is crying to be removed. It should be relieved by an adequate incision. Do not give 5 days antibiotic, if there is pus, it has to be taken out. Whether pus in the skin or in the chest as empyema, it has to be taken out. Tongue lacerations have to be sutured. If you don't suture them, they will appear innocuous. The child goes to sleep, it bleeds, swallows, aspirates. Okay, so tongue lacerations have to be sutured. So I'll conclude by saying that if you can't figure out a case, you please call the surgeon. He may not also know anything about it, but he'll bloody well do something about it. So I thank Srinivasan and the organizing team for having called me over, and I request your indulgence for having overshot my time. Thank you so much.